All right, so lecture 8 here is going to be the first of the lectures for the shoulder and pectoral region section. And in this lecture, we're going to talk about the shoulder osteology.
All right, so first we're going to talk about the clavicle, which is shown here, which is commonly known as the collarbone. And it's, as you can see here, it's a doubly curved bone here, and it extends from the acromion, which is this bony prominence of the scapula, extends from the acromion, and then it goes into the manubrium of the sternum here. And by doing that, it helps form both the shoulder joint here, and then it also helps connect the upper limb with the axial skeleton. So fractures of the clavicle, the main mechanism of injury for that are either falling directly onto the shoulder, falling on an outstretched hand, or having a direct blow into the clavicle. Now, the most common fracture site is the middle third, this part right here, where the change in curvature happens. And what the change in curvature does is it's an area of increased susceptibility to breaking, okay? And then, so what happens is the medial 2/3, so this section right here, this is actually pulled superiorly and medially by the sternocleidomastoid muscle, which is a muscle that comes down here in the neck and then attaches here on the clavicle and on the sternum as well. And since there's no forces bringing the clavicle down this way, it's going to get arched up like this way, that medial 2/3. You actually will see that in an x-ray. And then the lateral 1/3, this portion right here, is pulled by the deltoid muscle, which is this muscle over the lateral aspect of your arm and shoulder area. That's going to pull that, and then also gravity will pull this section down as well. So the fractures, they can affect very important neurovascular structures nearby, especially the subclavian vessels, which are the artery and vein which travel just deep to the clavicle, and then also the brachial plexus, which is running in this region.
All right, just to finish up, fractures of the clavicle, they're diagnosed with x-ray. Treatment, you put a splint and a sling on, or you can do surgery. Fracture mechanisms, there's two mechanisms here that we'll talk about. This is just a good obstetrics tie-in. One is during birth, the infant comes out, the preferred position is the infant comes out head first, and when they're coming out, their shoulder can actually get caught on this pubic symphysis, which is this fibrocartilaginous joint but connecting the two hip bones here. This is an inferior view of the pelvis, and this would be the opening of the birth canal. And they can get pressed against that, and that can actually fracture the infant's clavicle during passage through the birth canal. So that's one mechanism. The other mechanism is actually in the breech position. So the preferred is that the head comes out first, but what can happen is the feet are going to come out first, and that makes the birth process more difficult. So in order to make it, sometimes the obstetrician during birth has to actually intentionally cause a fracture in the clavicle to help get the baby out safely. Sternoclavicular joint, so it's a synovial gliding joint, and it consists of, this is the clavicle here, and then the manubrium of the sternum. So the sternum is the breastbone that comes down like this, and the top component of it, we'll talk more about this in chapter 3 in the thorax, but the top part of it's called the manubrium, and this articulates with both the cartilage of the first rib, and then the clavicle as well, and there's an interarticular disc involved here as well. So there's three bones here involved: clavicle, manubrium of the sternum, and then costal cartilage of the first rib. And it's involved, this actually joint's involved in a lot of movements and with the shoulder joint: elevation of the shoulder, depression, protraction, retraction, rotation. This would be both medial and lateral rotation. Elevation's obviously just going superior, depression inferior. Protraction is pulling the scapula up against tightly up against the posterior aspect of the rib cage. Retraction is actually pulling it posteriorly away from the rib cage. So just so you understand what those terms mean.
Now, on the posterior aspect of the skeleton here is the scapula, which is this triangular shaped bone like this that rests just up against the posterior surface of the thoracic cage. It connects with the humerus here, and it helps form the shoulder joint. And it has three surfaces: the costal surface, which is the anterior surface that faces the ribs; the lateral surface, which is this surface right here that articulates with the humerus; and then the posterior surface shown here. And we'll go through each of those surfaces and their unique features individually. But just some unique features I'd like to point out while we're looking here. So this is the scapular spine, which is a bony prominence here on the posterior aspect. It helps separate the supraspinous fossa and the infraspinous fossa, which are the origin points of the supra and infraspinatus muscles, respectively. Then you have this portion right here, which is the acromion, which is a bony prominence that juts out superiorly here, and then it goes out anteriorly. And then, as you can see, it articulates with the clavicle bone here proximally. And then also what I want to point out here is you have the suprascapular notch, which is this kind of depression in the bone here, and then there's the transverse scapular ligament which would join here. And just below that is where the suprascapular nerve is going to travel through the notch here underneath the ligament, and then the suprascapular artery is going to go over the ligament in that region there.
All right, so we're going to start off by looking at the costal surface here. The costal surface is the anterior surface of the scapula, and so if we look at the diagram here, this is the left scapula, this is an anterior view, and what we first want to pay attention to is the subscapular fossa, which is shown here, and this is a broad depression in the bone. It's the proximal attachment of the subscapularis muscle. Then we have the coracoid process, which is this bony projection that pushes out anteriorly from the superior lateral surface, and it serves as an attachment site for three muscles, the coracobrachialis, short head of the biceps, and then the pectoralis minor. Here we're looking at the lateral surface. This is the lateral surface of the left scapula, so this would be the anterior portion here, posterior portion here, and we're looking directly on laterally. So it articulates with the humerus at this portion right here called the glenoid fossa, which would be right here, or also known as the glenoid cavity, which would be in here. And the cavity is forming the socket portion of the ball and socket glenohumeral joint, which is also known as the shoulder joint. Then you have the supraglenoid tubercle, which you can see here, which is this bony prominence projecting superiorly, and it serves as an attachment site for the long head of the biceps brachii muscle. And then you have the infraglenoid tubercle, which you can see here, and this is a small bony projection projecting inferiorly, and it serves as an attachment site for the long head of the triceps brachii. So what's important to note here is if we look kind of at this view of it, and you have the supraglenoid tubercle, infraglenoid tubercle, they both receive a long head, but here the infraglenoid tubercle receives the long head of the triceps, and then the supraglenoid tubercle receives the long head of the biceps. Okay. All right, so now we'll look at the posterior surface of the scapula. The bone is divided in half by what's the structure known as the scapular spine, and that's this prominent structure right in here. And as you can see, it divides not so much in half, it's more kind of like 2/3 and 1/3, but it's thought of as the kind of the dividing line of the posterior surface. And then you have these two fossa that occur as a result of the spine. You have the supraspinous fossa, which is shown here, and this is a depression in the bone. It's just superior to the spine, and it contains the supraspinatus muscle, supraspinatus. Supraspinatus muscle originates here. Then you have the infraspinous fossa, which is this broad depression here, just inferior to the scapular spine, and that contains the infraspinatus muscle, or the proximal attachment of the infraspinatus. Then you have the acromion, which is shown here, which is really this bony prominence right here, and it's a lateral bone projection. It articulates with the clavicle to help form the acromioclavicular joint, or the AC joint, which we'll talk about in a few slides. And it's also the acromion, it serves as an attachment site for the deltoid muscle. And just a word about scapular fractures, they're pretty rare, and if they do occur, they usually occur in high impact injuries, such as someone who's in a motor vehicle accident or in athletic injuries. Another joint here involved is the acromioclavicular joint, for short the AC joint. This is a plane type synovial joint. It consists of the lateral end of the clavicle, so this right here, and then the acromion of the scapula, so this right here would be the AC joint. Okay. And it has articular surfaces that are aligned with fibrocartilage. The joint contains an articular disc and is enclosed by a fibrous capsule lined internally by a synovial membrane. So that's this right here. Here's the fibrous capsule. No muscles directly act on this joint, but it enables a significant amount of axial rotation and anterior-posterior movement of the shoulder. So even though no muscles act directly, it further enables a lot of, if you'll notice, your shoulder has a lot of freedom of motion, and so this is one of the structures that helps enable that. It's supported by three ligaments, and these can be important: the acromioclavicular ligament, the coracoclavicular ligament, which is really just these two ligaments together, This is the acromioclavicular ligament. This is the coracochromial ligament. Trapezoid ligament is lateral. Conoid ligament is medial, and let's talk a little bit more in depth about these. So the acromioclavicular ligament, it's in the name. It attaches from the acromion to the clavicle. It's also called the AC ligament. It covers the joint capsule to provide it reinforcement superiorly. It also provides horizontal stability to the AC joint. The coracoclavicular ligament, like I said, it consists of two ligaments, the trapezoid and the conoid ligament. Trapezoid is lateral, conoid ligament is medial. First, the trapezoid ligament attaches from this coracoid process to the clavicle, and it stabilizes the AC joint against horizontal, so this way, and vertical loads. The conoid ligament attaches from the coracoid process and attaches medial to the trapezoid ligament on the clavicle. It provides more significant support of the two ligaments, and it stabilizes the AC joint vertically, so this way. The head of the humerus, so that's this part right here, articulating with the glenoid fossa of the scapula. It forms the ball and socket portion of the glenohumeral joint. It has a greater tubercle, which is this bony prominence here. It's a lateral bony projection. It's a distal attachment site for several rotator cuff muscles, supraspinatus, infraspinatus, teres minor muscles. We'll go over these muscles in a few slides. These are 3 of the 4 rotator cuff muscles. There's the lesser tubercle, which you can see here, which is the more medial bony projection. It's a distal attachment site for the subscapularis muscle, which is the 4th rotator cuff muscle. There's the intertabicular groove. So you have your greater tubercle here, your lesser tubercle here, and then in between you have the groove. Okay? This is a depression in the humerus between the greater and lesser tubercles. It serves as a passageway for the tendon of the long head of the biceps brachii muscle. So you have this biceps muscle here. You have the long tendon, which is here. The short tendon goes up here and attaches on the coracoid process. That's the short. This is the long tendon that goes up here, and it runs through this groove, and then it actually goes into the shoulder joint and attaches onto the supraglenoid tubercle. It's also a distal attachment site. This is an intertabicular groove. It's also a distal attachment site for the pectoralis major muscle, latissimus dorsi, and teres major muscles. So several muscles that are in the back and pectoral regions that act on the upper extremity also attached there. So in this area right here, a lot of muscle attachments, because this is where there's a lot of movement to be made at this ball and socket glenohumeral joint. There's 2 necks at the head of the humerus. The anatomic neck is this part right here, and these are really just indentations in the bone. It serves as an attachment point, as you can see here, for the fibrous joint capsule. So this is a fibrous joint capsule of the shoulder joint. There's also the surgical neck, which is running down here, and this is actually more clinically relevant. This is a narrow point. It's distal to both the tubercles, and it's in contact with the axillary nerve. The axillary nerve actually wraps around here, which makes it susceptible to fractures in this region, and as well as the posterior humeral circumflex artery. And we'll go over these structures in much more detail in the neurovascular section of this chapter of the shoulder. Now, let's go into a little more detail about the shoulder joint specifically. Components: it's a ball and socket synovial joint formed by the head of the humerus articulating with the glenoid fossa. This is a lateral view of the glenoid fossa. So what is the glenoid fossa? It's depression in the lateral aspect. It's deepened by this fibrocartilaginous structure called the labrum, and you can see that here. Here's the labrum. The purpose of the labrum is it deepens the glenoid fossa, and so what that does is it provides enhanced stability to the humeral head. So the humeral head rests in here, and this labrum helps receive the humeral head and stabilize it and actually make it a little bit deeper fossa to enable the movement and stability. It's enclosed so the joint is enclosed by a fibrous joint capsule, which you can see here, that attaches from the borders of the glenoid fossa to the anatomic neck of the humerus, as we pointed out here. So that's the anatomic neck there. Several structures in place to reduce friction of the joint. Synovial membrane inside of the joint here, inside of the joint capsule. There's also several bursa, which we'll talk about in a second. So the synovial membrane, like we said, it lines the inner surface of the joint capsule, and it produces synovial fluid to allow a significant freedom of motion. So the subacromial bursa, it's located inferior to the deltoid muscle in the acromion. So here's the acromion here. Here's where the bursa would be, and if you remember, bursa are kind of like these pouches of fluid that help enhance frictionless movement of muscles and tendons. It supports the supraspinatus tendon, which is a rotator cuff muscle, so that the tendon is coming like this over the superior aspect of the bursa and the deltoid muscle. And so what it's doing here, like other bursa, is it's help reducing friction and wear and tear on this tendon and on this muscle to help prevent injury. This bursa can commonly become inflamed and is a source of significant pain in patients. This can just be from wear and tear. It can be due to kind of bony projections that come down from the acromion and irritate the bursa, general inflammation in the joint area, and that can irritate the bursa as well. Subdeltoid bursa, it lies between the deltoid muscle and the shoulder joint capsule. So the shoulder joint capsule would be about here, coming off glenoid fossa. Deltoid muscle, it's kind of running over the top here like this, if you look at it like this, and then so it's kind of in between this muscle and then the glenoid. It communicates with actually the subacromial bursa, which is up here, like we talked about on the previous slide. It supports the deltoid muscle and the supraspinatus tendon as well. Subscapularis bursa is located between the subscapularis tendon and the scapula. So the subscapularis muscle is located on this anterior surface of the scapula, and then the tendon kind of comes out this way, and where it inserts on the humerus there, it's located there to protect that tendon and help, again, reduce friction and wear and tear on the subscapularis tendon. Some ligaments that are involved in the shoulder joint, a lot of different ligaments, as you can see. This is a great image of that. You have the glenohumeral ligaments, which are these right here, which attach from the glenoid to the humerus. Coracochromial ligament, attaching from the coracoid process to the humeral. Coracochromial ligament, shown here. Coracoclavicular ligaments, transverse humeral ligament. So we'll go through each of these. Glenohumeral ligament, it's a group of 3 ligaments that all originate from the supraglenoid tubercle and stabilize the joint anteriorly. So you have the ligaments shown here, and it's broken into 3. And what happens here is you have the superior glenohumeral ligament, which is kind of the superior portion. If you were to divide this into 3s here, you can see the superior portion here, the middle portion, and then the inferior portion down here. And the superior portion attaches to the upper part of the lesser tubercle, so you can see that here, of the humerus. The middle attaches to the lower anatomical neck of the humerus, so down here. And then the inferior glenohumeral ligament attaches to the lower part of the lesser tubercle of the humerus, so down in this region here, right here. And these are all 3 comprised collectively are called glenohumeral ligaments. Coracochromial ligament, so that's shown here, coming from the coracoid process to the humerus here, greater tubercle specifically. It supports the glenohumeral joint superiorly here. The coracochromial ligament is shown here. It's all these ligaments, it's in the name. It's easy to remember what they attach to. Coracoid process to the acromion, and then lastly coracoclavicular ligaments. They provide support to the shoulder joint in addition to the AC joints. We already talked about coracoclavicular ligaments, which are shown here, the conoid and trapezoid ligament. So in addition to supporting the AC, they also support the shoulder. And lastly here we have the transverse humeral ligament, which is shown here as a great diagram. It's between the lesser and the greater tubercles. And it encloses the tendon of the long head of the biceps brachii into this intertabicular groove. And what happens is if this ligament becomes ruptured or torn, it can allow free movement of that biceps long head tendon, and which can result in serious inflammation of this tendon, and which can be a great source of pain in patients. All right, and that concludes our discussion of the osteology of the shoulder region.